Thank you. Thank you very much. In fact, it's a pleasure to be with you all and a pleasure to be on the Medgate Today TV. I think it's a very important message. We've been trying to prevent heart disease, and the World Heart Day signifies how we can remove the scourge of heart disease and decrease it, because heart disease is the biggest killer in every country. In every country, heart disease has been the biggest killer, but more so in Asia Pacific region, and of course, India is the world capital of heart disease. So it's important for every citizen to realize, what does this mean? Use heart for action means now it's the time for execution. Every one of us holds a role in society, be it our policymakers, be it our regulators, be it even a CEO in a company, be it even a supervisor, and be it every individual, can act and create an environment which is heart healthy. For example, if I was a CEO of a company, my first step would be, why haven't I got exercise machines in my workplace? If I can have my workforce having a cup of coffee or eating, say, potato chips in the canteen, then why haven't they got half an hour to be able to exercise rather than have a cup of tea? Use heart for action means that every individual can work towards decreasing heart disease, not just for your own self, but for the community, for people at large, for everyone who's in touch with you, for everyone's life you influence, for the policymakers and for environmentalists. It actually just makes a difference. So yes, if the world gets together to understand we use our heart and act, then we would be able to decrease heart disease across the world. So let's be responsible towards ourselves, and let's be also responsible towards everybody whose life we can influence and decrease heart disease. That's the message. So, interventional cardiology is a branch of cardiology where many treatment of heart disease, which used to be done by surgery in the past, can now be done without surgery. Now, we are not surgeons, we are cardiologists who then specialized in this field. By the way, interventional cardiology is a field which arose gradually 50 years ago by opening up blocked arteries with a balloon. So it is called angioplasty. In the 80s, when I trained in angioplasty, we used to open up the first ones, say, where blocked arteries could be opened by a balloon without opening the heart up, without opening the chest up, because prior to that, only open heart surgery, as one would say, had existed, which is opening the chest and really putting grafts on the heart. But once we started opening up blocked arteries in the cath lab, in a conscious patient, by going through the arteries of the groin and getting into the heart arteries, this field gradually became much better because it was crude in those days, and over the last 30 years has grown as the mainstay of treatment of heart disease and blocked arteries and prevention of heart attacks, treatment of heart attacks, treatment of angina. In fact, as you know, coronary artery disease or heart attacks is the biggest killer. Well, the mainstay of treatment of blocked arteries these days is interventional cardiology. And interventional cardiology has grown and refined itself to be a safe, simplified procedure done in cath lab. Conscious patients open up multiple blocked arteries, even in sick patients, has also grown into treating valves of the heart without surgery in conscious patients, has grown into treating multiple aspects of structural treatment of heart disease, and thereby leading to a discharge of the patient in 1 or 2 days, walking around with a safety which is greater than ever seen before, of more than 99% to 99.5%. So interventional cardiology has now become the established field of specialization in cardiology. And we are not surgeons, we're cardiologists who are able to do techniques and technology which is replacing surgery through minimally invasive methodologies in a very safe environment in cath labs rather than theaters, and patients' recovery is faster and mobilization is faster. But by the way, science has progressed to be complementary. I don't think we're talking about surgery or angioplasty or interventional cardiology. We are saying these are various, and we need every tool at various times to treat a patient with heart disease. Yeah, more and more, we know that intervention techniques have gone safer and have been very effective as science has progressed over the last 20 to 30 years. Everything's got more refined. And even surgeons have themselves joined us in multiple ways to promote minimally invasive techniques, because that's what the surgeons would also like to see. So in a way, we would say progress of science, especially for the treatment of heart disease, in the last 15 to 20 years has been a path which has been united between the surgeons and the interventional cardiologists. And if we do minimally invasive, be it through surgery, be it through angioplasty methodologies or interventional cardiology, which we say is angioplasty. You've heard of transcatheter aortic valve implantation or TAVI. You've heard of mitral valve repair of leaking valves through mitral clips, which is all non-invasive, minimally invasive. It is safer. It has less complications. It is done without general anesthesia, most of these procedures. It is done under sedation only. It is rapid discharge from the hospital, sometimes within 24 hours, after a major procedure of a valve replacement. It can be done at any ages, elderlies especially, where the risks of surgery are high. And it's rapid return to work within a week, full return to recovery, with no major cuts on the body, and therefore no major healing processes or complications. So in all ways, this is why the progress of science has been looking at less invasive methodologies. And by the way, these less invasive methodologies are not any lesser than surgery. In fact, in many a times, their results have been superior to surgery. So I think science is together progressing on the frontiers between the surgeons and interventional cardiologists to say, how can minimally invasive, the same things be done in a less invasive manner, with better outcomes, with greater safety and faster return to work. That, I think, is a very important aspect of what we do now compared to what we did, say, 20 years ago or 25 years ago. Right. So when there are blocked arteries, which cause heart attacks or cause angina, which is the biggest cause of death, by the way, is called coronary artery disease. The treatment of coronary artery disease have been three. Even medications have progressed in a tremendous manner to improve outcomes for the patient. And the two mainstays of those people who got severely blocked arteries or who can't carry on with their lives or have heart attacks or bad angina are either angioplasty or bypass surgery. So bypass surgery, a long-standing robust technique, involves general anesthesia, cutting open the chest, getting to the heart and putting grafts either from the leg or from the arteries inside, almost like flyovers across the blockade, so that an alternative path is created for the blood to flow when the original arteries are blocked and do not allow blood to flow and be given to the heart. And we're talking about arteries which supply blood to the heart muscle itself. And as you know, heart muscle is a pump. It is important. That is what gives us life. So that's bypass surgery. Then, of course, the chest is stitched back, and then, of course, it's a general anesthesia. The patient is a couple of days in the ICU, then gradually returns to work, gradually recovers, is discharged in a week's time, and gradually over a 4 to 6 weeks period recovers to get back to work. A robust technique, great for the people who need it, and life-saving. Angioplasty is the field of interventional cardiologists, which I explained to you came up 50 years ago and has gradually in the last 20 years progressed to finesse in a manner totally non-operative, same blocked arteries, which were treated by bypass surgery. Now we approach them under local anesthesia through arteries in the groin, get to the heart, go inside the arteries under X-ray guidance of a cath lab, are able to open up the blocked arteries with a balloon, then put what we call stents, which are metallic, stainless steel, nitinol, mesh-like devices which keep the artery open. And we do this procedure in a 45-minute period. The arteries get opened, treated, whether it's calcium, whether it's everything gets treated. The arteries are open, the blood is flowing normally. The procedure takes 45 minutes to an hour usually. Patient stays in the CCU for an hour, gets discharged for overnight, gets discharged the next day. And practically within a day is back to his usual daily activities, and within a few days is back to his full daily activities, including running around. So you can see the differences between the two. Of course, the risks are lesser because there's no general anesthesia, there's no cuts, so the risks are a lot less. There are some cases which can only be done for bypass surgery, where bypass surgery does extremely well. But majority of the cases now of blocked arteries and coronary artery disease are easily treatable by angioplasty with the advances which have happened in recent times. So we now believe both these techniques are complementary in a lifetime management of a patient with heart disease. At some stage he may need an angioplasty, at others he may need bypass surgery. 35% of the cases can now be treated by angioplasty. So we still consider these complementary. I would not say that anything is one versus the other. When I see a patient of heart disease, I have to decide how long can he continue on medication safely, at which stage should he actually have an angioplasty and continue non-surgically through his productive lifespan, and that at some stage in the lifetime, over a period of these 50 years that I've got to cover for the patient, he may require a bypass surgery to actually take him through that lifespan of 50 years. And that's what I start to say. It's not one treatment for a lifetime. It may be different procedures at different times of life. That's a very important question, because the mainstay of treatment of angioplasty or interventional cardiology is this drug-eluting stent. And you've heard of this multiple times. See, when angioplasty came in and we started putting these stents inside the blocked arteries to keep them open, it's almost like that you drill a hole, you create a tunnel in a mountain, and then you have to put a scaffolding inside and cementing inside so that it doesn't collapse back. Well, when we started angioplasty, it was just ballooning of those arteries and open the blocked arteries up. And then gradually over the next 6 months, the artery blockage would come back. Then we put this stents in, and they were made of just stainless steel. But we noticed that there was some reblockage happening still, and there was clotting, etc. So in 2001, the revolution took place, and that's why I say it's 23 years ago. Medicated, the stents, metallic stents, which had medicine covered on them, and this is a medicine which prevents reblockage. So when the stents are put in, the medicine is on the stent and then goes into the wall of the artery and prevents reblockage. And that's what the drug-eluting stents are. So the drug-eluting stents changed the whole angioplasty scene, because the angioplasty became safer, it became effective, recurrence of any blockages became rare, and then these stents started getting refined into thinner and thinner and thinner stents with more effective medications and more effective drugs on them. So we now in the fourth generation of drug-eluting stents, I'd say. Fourth generation of drug-eluting stents in the last 23 years, where we see they got refined to such an extent that they become effective, safe. And so now, the treatment of blocked arteries, when we say by angioplasty or say interventional cardiology, it is drug-eluting stents, and there are millions of drug-eluting stents being implanted for saving patients from heart attacks, saving patients from bad angina, saving patients from threatened heart attacks, and keeping patients alive in a situation that we are talking about as coronary artery disease is the biggest killer. So yes, drug-eluting stents have been a revolutionary change over the last 23 years, 24 years, but have progressed to a fourth to fifth generation of drug-eluting stents, which are so superior to even 20 years ago. So there are two, I'd say robotics, there are two aspects to robotics, especially in cardiology. I think robotics has progressed immensely in other specialties, urology, obs and gynae, are specific areas where it's progress, surgery. For cardiac surgery, it's there. It's advantageous in giving minimally invasive procedures. But sometimes to do complex surgeries, it becomes not so easy, because this heart is a structure where the surgeons have also got to go towards the back of the heart. And that's not very easy when it comes from going to robotics. So robotics has been around for heart for literally now close to 20 years, has progressed immensely. And the fourth generation of robots now are actually helping surgeons do more and more procedures, especially valve replacements of the heart, robotically in a manner which can be done efficiently and safely. As regards remotely, yes, that's a possibility. But I don't believe that's the future, because being at your patient's side is so important for any operator. Safety of procedures matters when you're on the patient's side, when you're the one who's actually next to the patient and able to take care of any complications. So I don't think I promote remote surgeries in any manner, especially not of the heart, which is, by the way, any slip or any wrong movement can be dangerous to the patient. After all, that's heart, that's his blood supply, and that's what keeps him alive all the time. And a small mistake can actually lead to a death on the table. So yes, fascinating arenas. Artificial intelligence is limited. Skills, your heart for the patient at his bedside and giving him the best at his table side, either in the theater or in the cath lab, that has to be the key. It's the patient put a trust on you. He didn't put a trust on the machine. And therefore, that's what you have to do. The machines are only a small part of what you deliver to the patient. Having said that, I think it's been very fascinating the way we've all progressed in the last 20 years to say that we now change valves, change heart valves. TAVI, it's called, without surgery, which was unthinkable 20 years ago. I must say, I introduced this procedure into India around 12 years ago. And now it's become, even in India, become the mainstay of treatment of valve disease. Treatment of leaking valves, which we thought were impossible apart from opening up the heart, stitching it all up, closing the heart, putting the patient on a bypass pump, taking him out the bypass pump. All these fascinating tools and technologies are clearly a joint effort by various experts, radiologists, interventional cardiologists, cardiac surgeons, everyone put together to say, let's save lives together. Let's do it in a manner which is safe and effective for the patient. Let's do and cross barriers which we never thought could be done 15 years ago and 20 years ago. Let's stretch this out to those situations where we didn't think even treatment was possible, and now we are making those treatment possible only because science and doctors work together to do it. So on this World Heart Day, remember, everyone has a contribution to not just treating heart disease, but to decreasing the global burden of heart disease and to prevention of heart disease. So let's get together and do it.
Thank you.